Okay, I want to jump on. We're going to go by first, second, third trimester and delivery, just talking about how, as maternal-fetal medicine specialists, or even as general OBGYNs, how things might differ a little bit for those that are over age 40. First trimester, is there anything differently that we should be doing when we have a patient that's pregnant for the first time or second, third, or fourth time who's now over age 40?
Yeah. So kind of piggybacking on our preconception visit. So if we haven't had someone in their preconception visit, first trimester is like that rapid fire visit to get all of those medical history details updated, making sure that medications are appropriate, and then thinking about screening. So one of the things that we know is higher in that age group is gestational diabetes. And so those patients should have early screening or an assessment of their blood sugars earlier in pregnancy. And then we would do that again later in the second trimester. And so that is one thing we think about. And then also thinking about hypertension and preeclampsia. So getting a baseline assessment, we call them preeclampsia labs. I don't know if you call them that over there.
Yeah, we do.
Or HELP labs.
Or I call them TOX labs, but yeah.
Oh, okay. Yeah. And so looking at like their CBC, and we want to make sure that their blood counts and platelet counts are appropriate, and their liver function and kidney function is all at baseline what we would expect it to be. Some providers might even ask their patient to collect their urine for 24 hours so that they can get a most accurate assessment of urine protein. And all of that is really just to establish a baseline so that if there is a condition that hadn't previously been diagnosed, we're aware of it in the first trimester. But also if complications do develop later on, we have something to compare it to.
Yes. Yeah, and one of the things I want to talk about too is antenatal screening. And antenatal screening is the various, we have a bunch of ways to do antenatal screening to look for the risk that the fetus might have a chromosomal defect. We know, and this is not talking about anyone over age 40 who conceived via donor egg. If they conceive via their own eggs, spontaneously or even with IVF, you know, antenatal screening is still important. It's still recommended that if you conceived over age 40 with your own eggs, and you even had those tested, PGT tested, you should still get antenatal screening because there are things that can happen during the development of the fetus that could still cause a chromosomal defect. So that's still recommended. But antenatal screening, I hear a lot that, oh, I don't want that because it doesn't matter if I'm going to keep my baby. I wouldn't terminate. That's not the only reason to get antenatal screening. Right. One of the things that I see a lot in those who decline it is they come back for their second trimester scan, which in those over 40, it's going to be a detailed assessment, and we'll talk about that. And we see something, not necessarily a major birth defect, but things that we call minor markers. And they don't have that baseline screening. And it's a little bit more difficult to counsel them about what that means in the pregnancy. When you get the antenatal screening, it'll give you a numbers risk about what the potential risk is for having a chromosomal defect in that pregnancy that you're carrying. When we have that and we can add whatever we see on the ultrasound of that, we can counsel you in numbers, which is a little bit easier to digest. So having the information is not just because you would do something or act on it, but if you see something on ultrasound, it helps us to better educate and counsel you about what that means for your pregnancy. Do you see that in some of your patients as well?
Oh, absolutely.
Yeah.
And I feel like we don't talk about the limitations of screening as well as we should too, just because I think some patients come in and they've had the screening and they're like, there's no chance my baby could have anything. And although our screening is really good, it's not 100%. And so talking about just all of the nuances of testing sometimes can get overwhelming for patients, but thinking about screening, but also diagnostic testing with an amniocentesis is something that we always touch on for moms in this age group.
Yeah, and anyone over age 35, and I believe this is pretty much in every state, can get just based on age alone can get a diagnostic test, whether it's with CBS or an amniocentesis. That is supposed to be covered by insurance companies, so I hope that's the case. But that's just based on age alone. Again, you don't have to have that done. It's not something that's required, but it's something that most all of us, I know I do, and I'm sure you do too, that's something that's going to be discussed. And again, it's not to tell you that, oh, something's going to be wrong, but it's your right to know that you have that option. And sometimes people get a little put off when I bring it up, but that's what my job is to talk to you about all these things and the realities of being pregnant, especially over age 40. So again, it's still your option. Genetics counseling is also an option as well. Some MFMs, my group, we do a lot of genetics counseling, but not all MFM groups do, and they utilize a genetics counselor. So you might have the consult with Dr. Johnson or myself and see a genetics counselor, or have that opportunity as well. So that's another option that you can use to investigate more, talk more about what your risk is of having a fetus that's affected with the chromosome. Talk about the difference between someone advanced maternal age, this is over age 35 and especially over age 40, getting a detailed anatomy scan and a fetal echo versus someone who's of a younger age group just getting a basic scan. What's the difference between those two types of ultrasound assessments?
Yeah, so really kind of high level, the difference is the amount of images that we take. We have, based on our ultrasound guidelines, there's a society, AIUM is kind of what we look at when we're thinking about ultrasounds. There's a checklist that we have for kind of a basic scan. And so that's going to be someone who does not have a condition that predisposes them to having a fetus affected by birth defects. And then there's the extensive scan, and the extensive scan looks at each structure in more detail. And so it is a scan that you automatically get when you're age 35 and above. And then the fetal echo, as I stated before, is a scan exclusively for the fetal heart. And so that is something that we also have a kind of a guideline on who qualifies for getting that scan. Or if something comes up during your basic scan, it might put you on the track to getting an extensive scan or a fetal echo. So there's definitely some fluidity in who gets what.
Yeah, but most individuals over age 40 are going to get that detailed anatomy scan and the fetal echo. And that's just where we're looking at a lot more views of the baby to look for. I don't know how you describe it. This is how I describe it. When we look at the baby, we're looking for two types of things. The first would be the obvious, the major birth defects or major defects, like a cleft lip, a hole in the heart, something anatomically, structurally wrong with the brain. Those types of things would need to be addressed once the baby's born and could potentially cause there to be certain effects in the baby as the baby grows. Whereas if you look for minor markers, and there's a whole list of them, I won't go through all of them, but one of the most common ones you might hear of is an echogenic intracardiac focus. What's the other one? The chorioplexus cyst. Those types of things are called minor markers. They're not birth defects. They don't cause dysfunction of the baby. When you start to see more than one, then it does alter the risk of the fetus potentially having a genetic abnormality or chromosomal defect. So those are really the two categories we see. So you may see a major defect, you may see one or two minor markers, even in those under age 35 that might change that basic anatomy scan to a more detailed anatomy scan or extensive scan. But when we're talking about those over age 40, they're going to get that extensive scan where we're definitely looking at the minor markers and the major defects. It's also important, again, when we have any kind of antenatal screening when you see those types of things to better counsel the patient as well.
Exactly.
One thing I also want to talk about is the increased risk of stillbirth in those over age 40. Again, this is another thing that people don't like to hear, but why do we need to talk about this? Why do we need to educate and counsel about this?
Well, again, I think if it was me as the patient and I had an outcome like stillbirth, I would feel slighted and heartbroken if it had never been brought up to me. And I think that it's important to talk about these risks so that we can minimize them and do what we can to decrease risk. And so for us, when we think about increased risk of stillbirth, that's when we start to introduce antenatal testing or some type of assessment of the fetus during pregnancy. And so some of you may be familiar with the non-stress test, where you go to the office and your doctor monitors baby's heart rate and contraction activity, and it's just an assessment of fetal well-being. Or again, that's a way that we use ultrasound. And so for those over age 40, antenatal testing is typically recommended, and your paper does a great job of stating that, there aren't super clear guidelines, but I think the general consensus is that risk of stillbirth is increased. And so there needs to be some discussion and also probably some antenatal testing.
Yeah, so if you're thinking about antenatal testing, again, Dr. Johnson mentioned non-stress tests, and then another common one might be a biophysical profile. When we do those for the start antenatal testing for someone with like diabetes or high blood pressure or some other type of fetal or maternal complication, that's typically done at 32 weeks. But if you're talking about age alone, if you're 41 and that's it, so not everybody does it. Some people do, and then but there's no recommendations, and it hasn't been shown that based on age alone that it changes neonatal outcomes or pregnancy outcomes doing surveillance. But if you're over age 40 and you don't have another medical reason to do antenatal surveillance, you may want to talk to your doctor about it. Whether it's starting NSTs at a certain gestational age, it's probably not going to hurt, but there's no evidence that it helps either, just based on age alone. We have more of the evidence if you have age plus chronic hypertension, age plus diabetes, age plus fetal growth restriction, then that becomes more clear. But, you know, it's definitely something to be considered. And I don't think we made a hard recommendation just based on the age alone, but it's something that definitely needs to be considered and discussed, right?
No, you did not.
Yeah.
And also just having trained in a different place where I'm now practicing, there's nuances between institutions. And so don't be surprised if you're talking to your provider and they say something that might be a little bit different than what we're talking about here. And I think that that is a perfect opportunity to just bring up your concern. And if it's something you've read about and just want to know why you do or do not get testing, that is a great question.
Let's talk about delivery, and then we're going to wrap this up. Okay, the first thing I want to talk about is I hear a lot. My doctor said I'm 39, I'm 42. I have to be induced at 39 weeks, or I have to deliver by C-section. What are your thoughts on either one of those recommendations?
Yeah,
I mean, honestly, babies over 35, I hear it all the time. That providers
I know you do. I've heard it.
I hear it. You know, I know, but it's happening a lot. So let's talk about first. They're over age 40. And is induction at 39 weeks an absolute?
So nothing is an absolute. I tell my patients when we give recommendations about delivery, that is based on the guidelines we've established from studies. Some of those studies are more recent and some aren't.
And some are better than others.
And some are better than others. And so our recommendation that someone over 40 should be delivered at 39 weeks comes from the stillbirth risk and the increased risk of stillbirth after the due date. But I tell my patients, if this is something that, like, if you just see they're heartbreaking when you're talking about an induction because they want it to go into natural labor, it's something that it can be an ongoing conversation, but I think we just have to be very clear about what the risks are and why we're giving our recommendation. And so, again, just joint decision making when it comes to those conversations. And then as far as cesarean delivery, I absolutely support vaginal birth. And our recommendation would be that anyone who is willing to attempt for a vaginal birth should get that opportunity, especially because it decreases the risk of postpartum complications. Thinking about severe maternal morbidity and the things that we discussed earlier in the conversation, a cesarean delivery is a major surgery. We do them all the time, but it's still a major surgery. And so a vaginal birth is definitely a more optimal delivery mode if that's the safest mode that's determined.
Yeah, and we're talking about just getting a recommendation for cesarean just based on your age. Now, someone who's had cesareans in the past, that's a different ballgame because you're always entitled to have an elective repeat. But if someone tells you you've never had a cesarean, but they say you're 40, you need to have a cesarean, there's no recommendation, there's no data to support that. Now, we do have some studies that show that those over age 40 are at increased risk for having a cesarean, and that's true. There is an increased risk. We don't really know physiologically why that is, but some problems with the rest of labor or failure to progress that would end in a cesarean section. But it's not that everyone, that's not saying that everybody needs to have a C-section that's over 40. I am very pro vaginal birth. I am very pro trial of labor after cesarean in all my patients. So, and again, this is where we're practicing. We have the facilities do that. We have the resources to offer that to all of our patients, but there's no reason that you have to have a C-section just based on age alone. For induction of labor, what we wrote on our paper is elective induction, especially with some of the newer studies that we have about the benefits and other patients, otherwise low risk patients for induction of labor at 39 weeks. It should be considered in those over age 40. However, with the shared decision making, meaning between what the patient wants and what the provider has recommended, the patient says to me, I want to see what happens. Okay, then I might say, you know what, let's go to 40 weeks. If you're still wanting to keep going on, then I'm definitely going to institute NSTs or BPPs. But I have to admit, and I will tell my patients this, if you're over age 40 and you're hitting that past 40-week mark, I'm going to be nervous and I'm going to be worried. I am. That's based on what I know. That's based on what the data shows. But that's my conversation, and they have to be comfortable as well. Induction of labor or elective induction of labor, meaning after 39 weeks, is not something that has to be done for anyone. It's a recommendation. And what you do is you talk about why you're recommending elective induction after 39 weeks, what the pros and cons are, and then what does the patient want. But you got to give them that information. And being over age 40, continue your pregnancy much past 40 weeks is a risk factor for having some adverse outcomes, and we have to address that, right?
Absolutely. I can't say enough that it's our job to tell you all of the possibilities, and then you have to make the best decision that you as the patient feel comfortable with, because I think it goes back to disparities and talking to patients about what they want versus what they felt like their provider wanted, and the dichotomy of patients not feeling listened to. I think everyone deserves to feel like their voices were heard and they were a partner in their care.
Yeah, I think it's the being talked at, or I'm the doctor and this is what I do. But we got to give them a why. Why? I mean, if my 5-year-old asks me why, I'm going to try to explain why. Why would I not do that with my patients? You know, but for some reasons we're hesitant to do that, and I hear that all the time. But you know, especially when it comes to something that has a gray area or some wiggle room, we've got to allow them that wiggle room if that's what they want. But it's our job also to give their whys, or I personally do this, or this is my recommendation based on what ACOG says, what SMFM says, what this newest study says, what my personal experience is, what I know about you as a patient, what I know about your history. These are the reasons why I'm recommending this. We are allowed to do that. We can't just go in and just wield our doctor hat and say, this is what I know is best and you need to just accept it.
Right. No